We just a quick recap. So the last 3 weeks have been two trips. I think in the last 3 or 4 weeks, we had the ASTP conference in DC. Saw a few of you there, so that was fun. And then we just were at Vive in Los Angeles here this week. We just got back late last night. And then we have a week of rest, theoretically rest. And then we're all, I know many of us are headed to him. So we will, I'll talk about that in just a minute because we will actually be there, have a pretty good sized Zen contingent, and even a booth at HIMSS this year. So if you're, we'd love it in the chat if you would put in there, if you are attending HIMSS, just throw a note in the chat. That would help us. And then we'd also know, even if I don't acknowledge it here real time, I'll know, and we can make sure we make a connection while we're there. All right, we are a little bit over, so I will go ahead and get things rolling here. So our topic today is putting the trust back in trusted exchange. And while my comments may be more directly associated with national network-based exchange, Carequality and TEFCA, I do know that we always have many of our regional health information exchange friends joining us. And I just want to call out before we get started that one of the very important roles that regional health information exchanges play is really trust being key. Health information exchanges do a fantastic job at a very focused community level of building trust across all the participants. And I do find it notable that we're going to talk about some of the things that are going wrong, that are kind of negatively impacting trust at a national level. And I just want to acknowledge the many years of data exchange that's happened with regional health information exchanges without those associated issues. It's not to say there's never been an issue, and I'm sure the regional HIEs get frustrated sometimes with maybe some concerns about lack of data sharing with certain folks in their community when they're trying to build those coalitions locally and regionally. But I just want to call that out. I think it's important. And I also think it's a reason why I hope to see more regional health information exchanges actively participating outside the context of a health exchange. Regional HIEs have been very historically involved in participating with the health exchange network, but have been a little bit slower to get involved with things like Carequality or TEFCA. And I think for good reason. There's got to be a good reason and a good value add for your community. But I think you've just learned, you have so much knowledge and experience in how to build trust that we'd love to have your voice. So for those of you who hopped on this call, I greatly appreciate it. For those of you who might be joining our event for the very first time, I know we've spent quite a bit of time inviting some folks, some newcomers that may have actually joined us. I just want to, for those of you who don't know what we do, we're an interoperability platform company. We also have a great team of subject matter experts, but I think in the context of a lot of the educational work that I do here on my Marilee's office hours and just kind of convening a community that where we can have a conversation with each other, that is often in the context of nationwide data exchange network. So Carequality, Health Exchange, Commonwealth, and TEFCA. And then just like I mentioned, we are going to be at HIMSS, and we actually have a booth. Actually, it's probably better framed as a kiosk. It will be in the Interoperability Smart Experience Pavilion. And I know there's a few of you that will spend quite a bit of time. Holly, I'm looking at you in that booth. So I look forward to seeing you guys there. All right. So let's dive into the topic here. So one of the reasons why I wanted to kind of focus on and have a conversation about this today is that we did have at the beginning of January a press release come out that Epic was suing Health Gorilla, and that is kind of on top of a lawsuit that happened and a dispute that happened between two Carequality implementers, Epic and Particle Health, back in 2024. And I think many of us who work to try to build trust in these national networks were very disappointed. I would even say sad that this second dispute has emerged and has resulted in a lawsuit. And even though and Epic and Health Gorilla are both Carequality implementers and QHINs, and so it's frustrating to say the least that this is now touched, TEFCA-based exchange in some way potentially. And I think there's a lot of impacts when we're trying to convene trust under a common data sharing agreement with very specific, well-defined exchange purposes. When something goes wrong or something, potentially goes wrong. And so I thought it would be a good time to just kind of come together, think through a little bit what those impacts might be, both good and bad. They're not always all bad. So I get my right window here. So looking at it from the negative impacts when these kind of disputes and lawsuits emerge. I mean, one thing that I heard multiple times in the past since January is, people kind of going, oh, maybe I shouldn't participate at all. Maybe there's risk there that someone might think I'm doing something wrong, so I'll just sit on the sidelines. So I think it absolutely can slow adoption, both from a health tech vendor perspective as well as a healthcare provider perspective. The other thing it does is it definitely forces the community back to the drawing board on, written, published policy and procedure documentation. Under TEFCA, we call those SOPs. And under Carequality, they might be implementation guides or just, certain policies related to certain exchange purposes. And then that can just add a lot more friction to bringing more people onto the network because maybe the business process has gotten increasingly complicated. Sometimes this results in a narrowing of who can participate. And I would say that one of the, I think, unintended consequences of the first lawsuit is the definition of required treatment under TEFCA, which I think was seeking to solve some problems and add some clarity there where there was maybe some gray area that the first lawsuit shed some light on. But it also is having an impact on providers who think they're covered entities, but maybe they're private pay and they don't realize that they've been kind of carved out of TEFCA-based exchange. And then in addition to that, some of those changes at TEFCA actually roll down to Carequality. So even though maybe Carequality hasn't explicitly adopted some of these more narrow definitions like the required treatment under TEFCA, large EMRs, and certainly Epic is one of them, has adopted some of these business rules, specifically required treatment and the associated vetting. And so now essentially Carequality and TEFCA have the same rules around required treatment, because if you don't follow that vetting path, you won't be able to onboard a new Epic, a new Carequality provider without jumping through that hoop during Epic's phone book review process. So all of these, these negative situations have absolutely had an impact. It's making life more complicated, but it's also, and this is where I think we look at it from a positive perspective. These disputes and these issues, just continue to force us to have these hard conversations. What is unclear about the business rules? Who should be participating? What about fairness and balance? For those of you who have been involved in your security frameworks in your organization, something like High Trust, for example, risk management is just a critical piece of that puzzle, assessing risk, thinking about mitigating risk, and then, deciding where, when you all things considered, there is such a thing as accepting a risk after applying your mitigations. And so I think, we're having hard conversations, but I think good things come from those hard conversations, and that iterating over written procedures and policies almost always makes things better. Sometimes we may take a step backwards and we have to, iterate again to keep moving forward. But I think that iteration generally moves us forward in a positive way. And then finally, I think it validates how important it is to not just get stuck in the treatment exchange purpose. There are a lot of valid reasons to exchange data that fall under other HIPAA or other national network exchange purposes. And I think TEFCA, has done a really good job of outlining a lot of alternative exchange purposes. And now we're just having the adoption discussion. So certainly individual access services that we'll talk a little bit more about today, some of the newer operations exchange purposes. And I was super excited. We're going to talk about TEFCA and some of the changes that have happened. And, there's continuing to be more detailed definition around payment and operations type use cases under national exchange and even other, use cases. And I think these are vitally important so that, no one's trying to twist themselves into a pretzel or not clearly understanding the exchange purpose. So I want to pause there. Holly, I know you're on the line. I don't want to put you on the spot, but I would love to maybe get some comments from you. You certainly are very close to the heart of these conversations, and like me, are very active in the governance groups, and would certainly be curious your perspective.
Marilee, I think let me answer as a provider.
Oh, great. Perfect.
Because as a physician, everyone not only swears a Hippocratic oath, but we are trained to completely protect our patients' data. And I joke that when someone tells me a secret or I hear patient information, I put it in a different file in my brain that's closed off. And so as a provider, when there's a threat that your patient's information is being leaked to inappropriate sources, it really squelches your desire to participate. Although, on the other hand, you're greatly appreciating the fact that you get data that you need to take care of your patient. So it becomes a true double-edged sword. And I can't even emphasize how critical it is to make sure that we catch bad actors and eliminate them.
Definitely. And I'm going to talk a little bit about the steps that, that TEFCA is taking to kind of relook at the vetting to try to do a better job if bad actors are getting into the system. And I do want to be clear, I have neither Holly nor myself have any sort of inside information on these lawsuits. But I agree with Holly 100%. We need, all of us collectively as a community need to do our due diligence better, because if we just try a little harder, and I think that's really about what some of these proposed changes are trying to get us to, that we'll talk about here in a minute, we should be able to identify the bad actors with some extra elbow grease, and just taking a breath and moving a tiny little bit slower is okay. And especially because getting that trust back in the system is what's going to make sure that the providers are there. Because if the providers are not there, we're done, we're sunk. And we've come so far, in the last 4 or 5 years that we want to continue making forward progress. And I know, Holly, you're a big advocate for capturing consent. And I know the RCE just published a paper, I'm going to touch on that, around operationalizing patient consent and starting to, bring that more to the forward. I know it's an important part of individual access services where, the patient has to do a lot of opting in, as part of using that digital health app. But I think, Holly, you feel very strongly that consent can play a bigger role.
I really do. And I think it's important to indicate exactly what organization or what areas of use cases you're consenting for. And I don't think it's a burden on provider organizations. I think everyone on this call will remember when you first went to a specific provider organization, you had to sign a consent to treatment. And generally, that consent to treatment included sharing your information with your payer. So it would be adding specifics about use cases and what use cases you consented to share your information for.
So it's just kind of an update to the patient registration process. And I know I have seen it. I have absolutely seen the providers asking me if I'm willing to share my data via, for example, the Regional Health Information Exchange in my communities at the time. And by the way, if you have a question and you're a little hesitant to jump in, don't hesitate to, if you have a question or just a comment, throw it in the chat. I've got folks on the Zen team, Jessica and Erica, keeping an eye out for those for me so they can interrupt me and kind of call those out. But we'll keep going here. So I have people ask me this, so this is my opinion. What should you take away from this as far as, what do I think about it? And I think, first of all, the most important message here is if you meet the exchange purpose requirements for TEFCA or Carequality, I still absolutely believe it is safe to engage in nationwide data exchange. Both from a provider's perspective and from the health tech vendors who are trying to enable innovative workflows, many times sitting next to those EMRs and acting as delegates or doing individual access, those digital health apps that are represented here on this call today. Those of you who are following by the rules, it's okay. And it's the communities, those of us who act as gatekeepers, the QHINs, the implementers, and the on-ramps. It's our job to just get better and better at doing the homework. I also think we all, as a community participants, need to bring a big dose of patience. We are going to be iterating to make things better, and so the community has to work together to do those iterations, to make adjustments. And I know some of you are on the front line of some of these new use cases, for example, like individual access services, and it may get frustrating that change keeps happening. But it's all to improve things, approve adoption, make it easier, remove the friction, but do so in a safe way. Elizabeth, I see your hand up.
Thanks, Marilyn. Yeah, I just wanted to double click a little on what was just put in the chat. And this is sort of the challenge, I think, to the field. And that is patients sort of getting confronted with a complex legal document with all this consent at the time of trying to check in for their doctor visit or their child's doctor visit. This is not consent. And I think we are lying to ourselves and we are abusing the trust. And I do appreciate the perspective of, in some ways, we are leveraging the trust relationship that our provider community has with their patients. And the fact that I think, oh, my doctor is a good doctor, and surely they wouldn't be actually selling me down the river. I just think we need to be intellectually honest here that we have created a coercive trap for consumers. And under the guise of, better care, which is important and no one's disputing that, but I do think we are abusing the trust of consumers. And what needs to happen is there needs to be disaggregated consent. It needs to be informed consent. It needs to be explicit consent. For example, Epic has put in front of their all the providers that use Epic systems, they have said that they've essentially undone HIPAA by making patients who are checking in for a simple doctor's appointment agree to hold the provider harmless, to allow data to move into their Cosmos ecosystem. These are all things patients absolutely do not envision are happening to them. And that also affects their biomaterial. So it's not just the ones and zeros, it's our cellular material. So I appreciate and want the innovation of having this important data ecosystem built, but it absolutely needs to be disaggregated for patients, and that is not being done currently. So I can't strongly emphasize enough that we can't go at the speed of making the system work, but basically absconding with all the patient rights.
I I find that really interesting, and I love it when folks show up on these calls that bring a completely different perspective. Elizabeth, I am very frustrated personally, being a healthcare consumer, about how hard it is to do individual access services under TEFCA and all the extra hoops that the digital health apps have to jump through. And then the extra hoops that Epic, and I have a lot of, and Holly and I both have some good friends that work at Epic, and I really like them as individuals. But it is interesting because what we hear is that, well, we have to make you jump through all these hoops, because basically what I was told in the last 3 weeks is that we don't trust the consumer to get my own app, read the privacy and security notice, and ask for my data, and then manage my data. So therefore, I have to make me go log into my chart and have them remind me how I need to protect my data. And it makes it harder for me to get my data. And now what you're saying is, on the other side of the coin, I might be opting into things that I have no idea I'm opting in just by going to the doctor's office.
100%. And listen, it's disingenuous. Yes, patients can't manage their own data. We know that, but that doesn't mean we can't employ our own point of view and exercise our judgment. Right now, I cannot check into my doctor's appointment personally, just to put it in a very personal context, without agreeing to the whole panoply. And it's all now digitized. So I can't just cross out the portion that says, hey, you can't take my biomaterial and, do anything you want with it and give it to whomever you want. There's no capacity for that. So I think there's a lot of ruse going on here in this fight between Epic and Particle and Health Gorilla. I mean, I think they are exposing it, and I agree with you, that is useful. But we are not honoring consumer rights in this system. So these hoops, these are legalistic hoops that people have no idea are being done to them.
I am seeing that this is great. We have a lot of conversation happening in the chat. I'm actually I'm going to go through a little bit more, and then I think we can focus. Maybe we'll circle back and come back to the chat, just so that I can kind of make sure we covered everything. This is a great conversation. One of the other points that I wanted to make sure, for those of you who are health tech vendors or provider organizations, but especially non-traditional provider organizations that are maybe telehealth. And I know you guys have heard me say I use a telehealth service that's very important to me. It really helps improve the quality of my life. But I think that as organizations attempt to join, specifically the national networks, TEFCA or Carequality, you might talk to different on-ramps or different QHINs and get different answers to whether you're eligible or not, or what exchange purpose that you're eligible for. And I just wanted to kind of call that out. I think that some of the larger organizations may become risk averse due to these lawsuits, or maybe they just are trying to rapidly onboard a lot of new folks. And so they don't want to take the extra time to have to do some extra due diligence. And so just be aware that you may hear different things from different people. Our recommendation is that there are HIPAA attorneys that are also well-versed in the national data exchange requirements and definitions. We know who some of those people are. They've they're just friends of ours, friends of Zen's and friends of the community. We recommend that those are great folks to bring in to help guide you when you're a new organization joining TEFCA or Carequality, to help you navigate the process and help you put together the due diligence. From Zen's perspective, we're simply going to do the work that is needed, the due diligence that is needed, both in terms of participating in the conversations around what these revised vetting business processes should be, that we'll look at here in a minute, as well as just making sure that we know our customers really well. And those of you who are our customers have already kind of experienced that, but we'll continue to need to keep up and align with the changes as they occur as a reaction to some of what's going on. So just real quick, a couple of early impacts that we're seeing. And there is if you go to, just remind everybody on the Sequoia Project's TEFCA webpage, there is under resources, there is a topics and change management section, which is super helpful to know what actual changes have either been released or in draft or being considered. And there really is a push for transparency on things that are being discussed. And that's the two that I would ask everyone to take a look at if you're participating in TEFCA or thinking about it, or these two here that just got released here. I think it was the week of the ASTP meeting here a couple weeks ago. So that's what I'm going to be talking about. So one of the things is, and I won't go over it in detail today, but that's why I'm referring you to go check out the documents on the RCE's website. They are re-looking at the required treatment vetting requirements. And it's interesting because they're trying to do two things at the same time, which are kind of contradictory to one another. One is just make them easier to apply, because the existing rules are a little bit hard to wrap your head around. And I've tried multiple times to flowchart them for people, and it is challenging. So they're trying to simplify it a little bit just to make it easier to operationalize for the QHINs and the on-ramps like Zen is. But they're secondly also looking at the evidence, like what kind of evidence would be needed to prove that someone is a covered entity. It is important to read that, and even though the comment period closed technically February 20th, I think I was talking to folks, they were like, just send your comments in anyway, because it's going to be an ongoing conversation. I think personally, the evidence right now is too narrow, and I'm going to be making some suggestions to not because it's too narrow so much, but it's going to be harder to operationalize than they think it is. And that's kind of consistent with some of our discussions with the Commonwealth group, who we've been going through those in detail together also. The other thing is, and this is a positive, they actually discovered that they left off some covered entities in the first required treatment SOP. They're proposing adding hospice in, for example. Hospice is clearly a covered entity, and they were not listed in the types of providers that can participate in required treatment-based exchange. So that's a gap they're trying to fix. And then there was theoretically a conversation happening to try to address certain providers that are, for example, fee-for-service, private pay, free clinics, people that are clearly, providing healthcare treatment services, but aren't, falling in this pretty narrow definition of a covered entity, meaning you have to be doing some sort of electronic HIPAA transaction, like a claim or maybe an eligibility check or something. And they were looking to see if they could fix that by coming up with a couple of other, possible requirements to be considered participating in required treatment. I think the lawsuit's going to slow that down, but I have been promised it isn't off the table entirely. They've just kicked that can down the road a little bit. They want to get the hospice, and there may be a couple of other examples of covered entities that got missed. They want to fix that problem first, and then they're going to relook at filling a few of these gaps. And in fact, there's a pretty significant number of Carequality participants even that are falling under EMRs, that it has, that the EMRs are saying they can't move over to TEFCA because they don't do, they're not a Medicare or Medicaid or commercial payer type provider. And then finally, just that work around these other new optional exchange purposes and getting those optional exchange purposes to work. One of the concerns I have is that will all the QHINs support the optional use cases and truly put it in the hands of the providers to make the decision of who they want to trade, do data exchange with for these optional exchange purposes? If you have your providers wanting to do it, but the EMR or the QHIN isn't supporting it, well, okay, why did we do all that work to identify those new exchange purposes? So I think that's something important the community is going to have to work on, that, whether it's Epic or Oracle or Commonwealth or pick one, the QHINs need to have kind of a baseline of functionality. And I'm not sure we're there yet on some of these optional use cases. And then I also think we're seeing a lot of people believe that if we can just keep improving the adoption rate for individual access services, we've certainly made big strides in the last 90 days, that will help because it does put the patient front and center of being able to get their data, and then the patient can decide what to do with that data. And there's a big focus on improving response rates, and you'll notice that some of the suggested changes or the things being discussed fall under individual access services. And then finally, this is not necessarily directly related to TEFCA, but it is something that just happened and has been talked about recently. So I wanted to call it out for digital health providers, digital health apps. Certainly those that are already participating in TEFCA or are in the process of doing so. There's a lot happening with CMS outside the scope of just TEFCA. We've got the CMS interoperability framework, and we've got the CMS access program. And at the ASTP meeting, they talked about the fact that they are going to publish a list of digital health apps that will help, those providers participating in the access program, kind of provide, improve outcomes. And kind of associated with that is an effort that just, and I apologize because I don't know exactly how old this announcement is, but I think it's pretty new. Direct Trust and the Carequality Alliance. So the Carequality Alliance is a group of digital health provider apps that get together and are trying to drive towards some, best practices. And so Direct Trust, which is a certification body, and Carequality Alliance got together and came up with a certification program. We think there's going to be a very close tie-in to CMS for participation in the Medicare app library, for example, which is another initiative CMS has. So I just wanted to bring that to the attention of those of you on the call who have digital health apps. If you're not familiar with that, that link is there, and you can get my presentation afterwards. I would definitely be checking that out. I think that this is very much fundamental to trust, right? And that is these certifications, whether it's HITRUST for security, or SOC 2 and the other security frameworks, NIST, et cetera. I think because digital health apps are not covered entity or business associates, this concept of certification and adoption of best practices is going to be critical as digital health apps, join the national networks and play a bigger role in trying to help us innovate to improve health outcomes. Okay, sorry. So I'm going to pause. I just want to open it up a little bit. I'm going to take a quick look at the comments here. Leslie says, is it also to make the process smoother? I understand in California that the all or none participation in the HIE creates two pathways for care, paper and electronic. And I apologize because I'm having Leslie. Yes. Leslie, can you maybe talk more about your comment there?
Sure. I was attending a HEPA privacy and security webinar where people in California were commenting on patients not wanting to provide their sensitive information through the network because it included law enforcement through social work. And as a result, the care pathways differ because of that, because it was an all or none. They couldn't send it to the HIE because they didn't want the consent to go through. And so it goes back to the faxing and calling and trying to get paid care done that way. And the beginning of my point was related to the previous conversation about the process of consenting and having that flow through smoothly without, awareness of what the options were.
Oh, right. Yes, I see your comment above. I think one of the very, the concept of consent and global versus more granular level consent has been being talked about at the regional health information exchange level for many years. And Eric, I see you're on the call. I'm really curious what kind of conversations you guys have had in your community there in Oregon and Washington, because you're the executive director for that HIE. What kind of conversations are you having about consent in your community?
I think for most states in the regional health information exchange space, most of our consent conversations nowadays are oriented around substance use disorder, right? So it's 42 CFR Part 2 kind of consent. And in some cases, and we're just starting down this road here in Oregon, but it's more robust in other places. We start getting into FERPA, we start getting into school-based consents, education-based consents, social service-based consents. So as we start to think about this as whole person care, not just physical health care, not just behavioral health, substance use disorder treatment, as we start to think about them and, individuals and whether they're receiving, homeless services, food services, various social-based care services, consent is really where we're focused. I think for the most part, we have a couple of states that are still what we would think of for health information exchange purposes. We have a couple of states that are still what we call opt-in. New York and Nevada stand out as probably the two major states that still have opt-in policies, meaning data doesn't move over any network. National networks or local networks, data doesn't move unless the patient signs an explicit, I'm allowing my information to flow over a health information network. And for the most part, everybody's HIPAA based. And so when we start getting into, the points that Holly has made and Elizabeth has made in this call around consent and use of data, we don't talk about that much anymore at the regional HIE level. In part because I'll speak in this case for Oregon, we're community governed. And so we make our decisions based on what our participating doctors and our participating behavioral health systems and our participating hospital systems on what makes sense to them, what culturally and locally is acceptable. And sometimes it is local when we start dealing with, I'll use here in Oregon, women's healthcare, reproductive health. The way that we address data exchange for reproductive health is very different in the Portland metropolitan area than it is in Eastern Oregon, where we border the state of Idaho. What we do, what we allow to exchange over networks, what we allow to be shared gets treated differently. And that's the advantage of a local network, right? You mentioned that at the beginning. We have that trust, we have that convening activity. We know, right? We can kind of walk in the door to a degree. We can walk in the door at any hospital, at any system, and they know who we are, they know what we do, and we know them. And so when someone asks for information, oh yeah, we know what you're doing with that, and we know what the process is, and we've talked about that. And so we address that at the local level. So consent becomes a different conversation at the regional data exchange level than it is at the national level, than it is, when we're talking about the vendors, the tech vendors, the health gorillas and the particle healths and the epics of the world moving data versus let's move it as a community. Let's move it based on what we agree to as a community, not what the vendor thinks is right or what the vendor's attorneys think they can get away with.
You said something that was interesting, Eric, and it's a good segue as I move into some of the other conversations it's the vendor and their compliance groups, and there's so many stakeholders, and again, I do think that we're doing a better job, at least at the TEFCA level, compared to Carequality, just to pick on two national trust frameworks, of getting more people at the table talking about these things, as opposed to just a handful of people. Now, I will say, of course, the individual QHINs, carry a lot of weight, but the RCE, having spoken to many of them there in leadership, they really do want the sub-participant group to have a strong voice, and kind of counterbalance the really large companies that are participating. And to Holly's point, at the end of the day, it's Epic's customers that voices that should be most important, not just Epic, by themselves. And they do reinforce Epic. If you talk to Epic, they say, oh, it's our customers we're representing. Maybe in some cases that's true. Maybe some cases it isn't. But I do think hearing the patient's voice and the provider's voice, both equally important. Just real quick, one of the specific changes around vetting of organizations and providers doing required treatment is a concept called Know Your Participant. And this is where the QHINs and that would flow down to on-ramps such as people like Zend, who were a Commonwealth service adopter. So we're often doing the vetting on the behalf of Commonwealth as a QHIN. They propose some very specific kind of a profile that you build of your customer to pick up additional business details, to really better understand the business structure, and again, just to kind of make sure there's no bad actors that are positioning themselves as, for example, providers. And then also this concept of trying to make evidence gathering easier. And their example is an example, provide an 837 message. And I think they're going to get some pushback on that, but they're rather than giving a kind of a full menu list of a whole bunch of different kinds of evidence, they're trying to dial that in a little bit just so that it's a little bit more like a recipe book, as opposed to a lot of options that can get confusing. And the other area that's interesting is the changes around individual access services. There are a number of them. One is to get the ILA2 identity folks, so the clears and the ID.me's, to validate some additional demographic data, phone and email, I think specifically is called out in the discussion that they're having. And then also potentially add patient asserted demographics, which is a little contrary to the whole concept of ILA2. But what they're trying to do is just make sure that there's a lot of patient demographic data coming in so that the QHINs and the associated endpoints can have more data so that the quality of the patient matching out results, the algorithms, the results of that improve, both in terms of not having such an unrealistically high bar that nothing gets through, but also helping the more data points you have on the patient demographic side, the much higher certainty you have in terms of the patient matching. So that's a big conversation. And then the second one is really interesting because my personal opinion is that this proposed change, and again, not approved, is an attempt to shift the risk back to the digital health apps from a patient matching perspective. So what they're suggesting is that the the responders to an individual access services query would provide back the patient demographics that they used to get a match to the digital health apps. And then the digital health apps would have the responsibility of doing a final double check. Does that information that the EMR used to do the patient match, is that now causing your system to say, wait a minute, I don't think that's a match? I am concerned about that piece. It is definitely a significant, I think, additional technical step. But it's so it's kind of there's a business piece of it where it's a attempt to kind of shift the risk away from the EMRs back to the digital health app vendors if a patient mismatch occurs. And then there's this technical piece. And my personal attitude, and this is just personal to me, is that if it should be a negotiation, and if the digital health app vendors have to do a significant amount of extra steps, if you will, what's the win on the adoption side? There needs to be well, we'll do this as long as this solves this problem, right? And so we know, for example, Epic specifically requires a lot of extra hoops right now on the patient, on the healthcare consumer, that really can slow the patient access process down through TEFCA. So it's kind of like, well, is it a negotiation? And these two things are kind of it. If we do this extra step, Epic, will you kind of do what all the other EMRs are doing under TEFCA and just return documents without us having all these extra hoops in the middle? And that's kind of been my feedback so far to the RCE. I'm worried about ideas getting separated, and we make it starts to become unbalanced in terms of how we're making these changes. So nothing is finalized. Now is the time to get feedback in, read those proposed changes that they published, and get some feedback in. All right, I know we're getting close to running out of time, but I can get pretty quickly through this. This is just a really quick catch up on some of the things that were talked about at the ASTP ONC meeting. They talk about two lanes at ASTP CMS in terms of understanding the CMS interoperability framework in TEFCA. And the way they describe it, the CMS interoperability framework, which is a public-private partnership, it's all optional, is kind of an opportunity to move fast and break things. And TEFCA is a different lane that really is about moving more slowly, getting the details right, and scaling. And so you're going to see out of the CMS interoperability framework a lot of pilots, MVPs, voluntary vendors coming together to prove that certain use cases will work, and then some of those use cases might get adopted, with regional HIEs or at the national level. But they want to be able to iterate and a little bit faster to kind of prove some concepts out. So I thought that was an interesting way of thinking about it. ASTP says they still plan on having a pilot of the provider directory, which the whole point there is to combine multiple HHS directories into a single source. And the plea at the meeting was, be patient with us. It's going to be ugly at first, but please help us fix it. So I just thought that was an interesting quote. And then there was also, I would say, of all the different initiatives, I think the one that seems to be moving the fastest, other than the provider directory piece, is the kill the clipboard, this concept of patients pushing their information back to the EMR at check-in via a QR code. There's a FHIR data standard for this. And their goal there is to have their some MVPs demoed in July. So I think you'll continue to see progress around this whole all the things happening under the interoperability framework. And then this also is kind of tying into this Medicare digital health app, which has a tie into the CMS Access program. And again, kind of related to the Direct Trust Care and Alliance certification program for digital health apps. So a lot of emphasis at the conference that TEFCA remains very important, and trying to make progress on that. The SSA plans to be live on TEFCA by early spring, so we should be pretty close to that happening. The RCE one, just some other feedback opportunities for you. This operationalizing automated consent paper that's the Sequoia project published. They really would like feedback on that. So all of you who are interested in these consent conversations, if you haven't already, I'd highly recommend you read that paper and provide the feedback. And then just in terms of, again, trust, the more data we have about what is actually happening on the network, it adds a layer of transparency. So I think we've done a pretty good job of adding transparency on the front end in terms of the business processes and the SOPs and that process of making changes to those things. But we need more transparency in terms of what's really happening, who's participating, the volumes of exchange at a participant level, and the exchange purposes. For each one of the QHINs, what kind of exchange purposes are they supporting, and what are the message volumes for each one of those exchange purposes? Because I think sometimes we feel like, well, we're hearing people say there's all these providers on the network, and then but is it really happening in real life? So that transparency on the actual transaction reporting side by the QHINs is going to be a really important change. And then I am very close to being done here. The other, and by the way, I think I have the link here at the beginning of this. Yes, these events, the ASTP meetings were all recorded, and I personally missed a lot of them because they had a lot of separate tracks going on at the same time. And one of the important ones was, and I was pretty focused on the TEFCA track, but I am going to go listen to the information blocking track that was a half day. So it was quite long, several sessions over half a day. So what ASTP is saying that if they do intend, they're taking the information blocking enforcement pretty seriously. They're starting off with just providing notices of nonconformity going out to certified EMRs that have had reports of information blocking. And they emphasize that the most important way for CMS ASTP to get feedback on what's working and what isn't working under interoperability framework or certainly under TEFCA is making information blocking reports. That's what's getting it on their radar. It was kind of like, well, we can talk about it in this meeting, but if you really want us to consider it, put in an information blocking. I thought that was interesting. And then, Eric, getting back to your comment, from the stage, at this meeting, these were the government participants. They indicated verbally that they do have concerns about dominant tech gatekeepers using control over their customers and their data to stifle competition. So they literally said that out loud. So I think that was important signaling. Maybe this concept of balance and fairness, is coming into play here, hopefully. They also explicitly stated I think everyone knows that this administration is a big supporter and believer in innovation, and particularly in AI. And they want to continue to create an environment where smaller innovative companies have a space there, and it isn't all just about 3 or 4 large vendors. And then there's a number of changes planned in HTI. I think we're still in the comment period. Maybe it ends today for HTI 5. There, and then HTI 6 is supposed to be out for comment this mid-year. But they did make a number of proposed changes that they were looking for comment on around the manner exception changes under information blocking. And in trying to read through those, it seems like most of them were trying to make sure that they weren't kind of giving the big developers of certified EHR an out. I find those manner exception the language items pretty dense and hard to understand. But for those of you who are smarter than I am, again, I think you will continue to have a lot of conversation around that in HTI 5 and then probably HTI 6. And then, yes, go for it.
It's Erica. I just wanted to give you a heads up that there's about 6 minutes left on the clock.
Thank you.
And a couple comments and questions in the
Okay, perfect. perfect timing. Fire, they want to make fire more performant and usable at scale. We all are a big believer in that. And then I think notably, they really are frustrated with this kind of getting stuck in USCDI V1. And instead of having a whole bunch of USCDI versions, which small incremental changes, they really want to go big. And so expect to see a lot more data elements in USCDI V7, and then some efforts probably through their levers to try to drive the EMRs to move up that USCDI pathway. Okay. Let's see. Oh, yes, we're going to look for some new. Oh, yes, thank you. The version, the V7 draft is available. So yes, definitely take a look at that. I see there was some Elizabeth commenting back to Eric. I don't know, Elizabeth, if you want to comment on that at all.
Need to take the time. I think
Okay,
that works.
good. And Holly, you made a comment about consequences. Can you comment on that maybe to close us up here?
Sure. I think that very significant and very serious consequences need to be defined for bad actors on TEFCA. I think that that would reassure both patients and providers. And I think, again, I just think it's critically important to define that. And when that is proven, that those consequences are put into effect.
I think you're right on, Holly. It's a great place to land here. And there are some proposed changes in the vetting and business processes and the know your customer that relate to making sure that no one has that they haven't already been a bad actor or gotten turned down from another QHIN, so that they would literally you'd be able to cross-reference and know if people are QHIN shopping and are getting turned down because of non-compliance to the requirements. So I think there's a lot more that needs to get worked on there, but those kind of safety measures, and I think those are the kind of things too that Carequality is looking at. And I think we haven't talked much about Carequality, but I think there's no question that we'll continue to see TEFCA changes flowing down, even if it's not formally, informally down through the Carequality. If Epic, especially when it comes to some of the big EMRs where they can just adopt a business rule under Carequality without having to have there be a formal process, but it in effect becomes a policy. So yes, I think we'll continue to see alignment there. And Holly, you're right. We probably need to come up with some other creative but important ways of making sure that there is a price to pay for being a bad actor and trying to cheat. Well, everyone, thank you all so much for attending. Really, really appreciate this. Was a wonderful collaborative conversation, and I really appreciate everybody. So many cameras on, and so many putting comments in and participating in the discussion. And we will continue to do these once a month. We reminder to visit us at HIMSS, and we'll be publishing our next office hours. The date for that will be coming out soon, so be sure to look for that.
Thank you so much.
Thank you, everyone. Really appreciate it. Have a great rest of your day.